I take the pleasure to talk about the COVID-19 in HIV positive patients investigated for TB in the context of the FujiLAM study. As we all remember, in 2019, a new disease called coronavirus disease broke out, and it was declared a pandemic. We have lived with it since. Importantly is that COVID-19 pandemic has dominated the global attention, and in a way it has impacted the pre-existing public health concerns, including TB. Also, the clinical presentation of TB and COVID-19 overlap, so in a way it creates additional diagnostic challenges. Now, real-time world data on HIV, TB, and COVID-19 diagnosis is very important for understanding the impact of the pandemic on vulnerable populations such as HIV. So for this study, the objective was to assess the prevalence of exposure and infection by SARS-CoV-2 among the HIV patients who were being investigated for TB in the FujiLAM study. So to achieve this, we came up with the methods, and to define the design is that this was prospective, observational, ancillary to the study of the FujiLAM as presented already. Also, we had the two groups, where we had group 1, who had at least one symptom of TB, while group 2, these are participants who did not have the symptom of TB but had advanced HIV disease. So the participants' recruitment was done in October 2020 to April 2022, and 3 sites were involved in this COVID sub-study. So this was Uganda, Kenya, and South Africa. Again, laboratory procedures were helpful to be able to give us the questions being addressed. So to be able to achieve this, we did the PCR testing, which was proposed to all patients who had the symptoms of TB, and this is the clear definition of what infection is for this study. So any patient who had a positive PCR was categorized as infected. On the other hand, we also took off blood samples, which were used for antibody testing. So this is what defined our exposure. Anybody who had detectable antibodies was declared as having been exposed to SARS-CoV-2. So our findings, we had 1,466 patients who were enrolled from the 3 participating sites. And for today, we mentioned that we have up to 96% interpretable results, which we'll be able to share in this workshop. So overall, for the 3 sites, the prevalence of COVID-19 exposure was 29.7%. And as you can see in that table, we see that group 1 had 782, of whom the prevalence of COVID-19 exposure was 33.8%. On the other hand, group 2, the COVID-19 exposure was at 22.3%. So to show you the exposure by country, we see that Uganda had 33.5, followed by Kenya, and South Africa had 33.8, close to the one of Uganda. So also we did the stratification by CD4, and we see that the exposure positivity was higher in participants who had a CD4 above 200. Now, this kind of variation between the different CD4 counts had a statistical association. For the infection, it is also important to mention that we proposed PCR testing for individuals who had the symptoms of TB. That was group 1, and we had up to 49% of them accepting the test. Among those who participated, we see that the prevalence of COVID infection was 8.3%. So those are the ones who were positive for PCR. Importantly also is to show you that the 3 countries shared almost a similar burden, but Uganda had more infection than the others. We went ahead to stratify by CD4, And we see that there was more infection in the group, in the participants who had a CD4 less than 200. However, this association did not show a statistical significance. Now, when we combine the exposure and infection in the same table, like I already mentioned, we see that we had more exposure within the participants who had a CD4 above 200, and we had more infection among participants who had a CD4 below 200. So we have some summary of the findings, and we mentioned that we had 42 participants who had a positive PCR and also were positive for TB. 15 of them were positive for TB. So this co-infection between the two is very important to mention in this workshop. As a new disease, a number of assumptions have been made, so sometimes it is very important when you have such a study to also assess whether you can come up with the specific symptoms for a particular condition. So as we rightly see, most of the assessed symptoms between those who had a positive PCR and a negative PCR are almost similar. However, allow me to highlight that most of the positive PCR patients, they actually presented with difficulty in breathing, and also we see that they had runny nose as well as the loss of taste. The other symptoms being described are almost similar. Now, with the presentation of the three sites, it's very important to give you a snapshot of what it was for Uganda. For the Ugandan site, which was Mbale Regional Referral Hospital, the main FujiLAM study recruited 795 participants. Out of the 795, the COVID-19 exposure was detected at 33.5%. Now, per group, we see that 36.7 was for group 1 and 27.9 was for group 2. In terms of the infection, we see that the prevalence of COVID-19 infection was at 9.5%, and very importantly is that we had 26 patients who had a positive PCR, of whom 11 also had a confirmed TB. That is for Uganda. So from this study, we draw some conclusions, and I want to mention that we found a moderate to high exposure to COVID-19 among patients investigated for TB. And also importantly is that the HIV positive participants who had a CD4 less than 200 had a lower COVID-19 serology positivity as compared to those who had a CD4 count above 200. Now, this has an implication because we think that the level of protection for such a population could mean a lot, especially for the vaccination strategies, but also importantly, we believe that these people should be targeted as a priority, especially for the COVID-19 vaccination. Also, we see that a considerable proportion of COVID-19 infected patients were diagnosed with TB. So in a setting where you have the two existing, it's very important that they are systematically investigated. And as I already mentioned, the clinical presentation of both COVID and TB are not clearly distinct based on the symptoms as I presented in the table. I want to take this chance to acknowledge the different partners. So we have the participants, we have the MSF and the epicenter colleagues. We had the scientific committee. We also have the Ministry of Health partners from all the participating countries. We have the funders and also the Foundation for Innovative and New Diagnostics. Thank you so much for your attention.